So non-dependence producing substances encompasses a wide range of drugs and substances that are generally considered to have a low risk of physical addiction. They include over-the-counter medications, herbal remedies, dietary supplements, and recreational substances. While they may have not led to physical dependence, prolonged or excessive use can result in physiological dependence, adverse health effects, and other complications. As per ICD-10 guidelines, these substances are included: antidepressants, laxatives, analgesics, antacids, vitamins, steroids or hormones, specific herbal or folk remedies, other substances that are not product dependent. Misconception. Misconceptions surrounding non-dependence producing substances contribute to the challenges of recognizing and addressing these abuses. Some common misconceptions include perception of safety. Many individuals believe that non-dependence producing substances are inherently safe due to their accessibility and lack of physical addiction potential. This misconception can lead to their misuse or abuse without awareness of associated risks. Minimal harm. Non-dependence producing substances are often perceived as harmless, leading to belief that their excess or prolonged use carries little or no consequences. However, such abuse can still result in adverse effect on physical and mental health. Antidepressants. While drugs have been used effectively and appropriately to treat both medical and psychiatric illness, in the vast majority of patients, rate of prescription abuse have accelerated and have reached epidemic proportions. Another trend leading to increased access in the use of internet and what are termed non-prescription websites, which first came to the attention of law enforcement authorities in the mid-90s. Taking a careful history and risk stratification assessment, including a history of legal, prescribed, and illegal drug abuse, is an important strategy for reducing the likelihood of antidepressant misuse when evaluating a new patient. Laxatives. Laxative abuse is an uncommon but clinically important condition often associated with other gastrointestinal symptoms, as well as with disturbance in electrolyte and acid-base balance. A high index of suspicious, a detailed history, and a detection of laxative in stools or urine will establish the diagnosis once routine laboratory, endoscopic, and radiologic investigations have excluded common causes of chronic diarrhea. Analgesics. NSAIDs are efficacious and have wide margin of safety. However, they do have potentially serious side effects that can occur even when they are taken in appropriate doses. Acetaminophen, ASA, and ibuprofen are all among the top 10 drugs in the United States Drug Abuse Warning Network statistic for emergency room contact resulting from self-administered drugs usually with evidence of suicidal intent. One problem in the recent literature is that most of the data are based on self-reported drug intake. Over-the-counter analgesics are often not mentioned when medical history are taken. Even when specifically asked, people often underreport their use of these agents. Antacids. When antacids are taken for a long time or too much in quantity than directed, it can potentially cause serious health risk due to various adverse effects on the body it brings with time. These should improve once you stop taking the medicine. Some of the important side effects one need to be aware are constipation, muscle pain, hypercalcemia, poor iron absorption, and diarrhea. Vitamins. The result of studies on potential risk associated with the abuse of vitamin supplements, which until recently have been considered not only high efficacious, but also completely safe. Particular consideration is given to vitamin A, E, D, and C, the necessity to control the intake of vitamin supplements and even to strictly supervise the supply to higher risk patient is highlighted. Recognition and intervention. Enhanced education, health healthcare professionals should engage in education campaign to increase public awareness about the potential risks and consequences of non-dependence producing substances abuse, screening and assessment, implementing routine screening tools and assessment can help identify individual at risk and facilitate early intervention tailored to address the specific need and challenges associated with non-dependence producing substance abuse. This may involve a combination of counseling, behavioral therapies, support groups, and pharmacotherapy is appropriate. Conclusion. In conclusion, the abuse of non-dependence producing substances is a significant issue that often goes unnoticed due to misconceptions surrounding their safety. However, their misuse or abuse can lead to adverse health effects and psychological dependence. By recognition and addressing this form of substance abuse, healthcare professionals can promote better health outcomes and enhance the well-being of individuals. Through education, increase awareness, and comprehensive intervention, we can combat the abuse of non-dependence producing substances. It is essential to dispel misconceptions and educate individuals about the potential risk associated with these substances. By implementing screening and assessment tools, we can identify those at risk and provide tailored intervention that addresses this specific need. This is the references.
Coming on to the pharmacokinetics, this drug is 95% bioavailable and it reaches peak concentration in about 4 hours. It is a highly protein bound drug, and generally the dosage is not affected in people who are suffering from hepatic or renal impairment. It is metabolized by cytochrome 3A4 and cytochrome 2D6. On metabolism, an inactive metabolite is formed, which is DM3411, although it does not contain any active constituent in it. So the drug is excreted in less than 1% unchanged form in urine, and less than 14% is excreted in feces in unchanged form. And the half-life of the drug is 91 hours. Coming into the mechanism of action, brexpiprazole basically works by modulating on neurotransmitters. Majorly, it works on serotonin and dopamine. So here is the mechanism of action. So mechanism of action acts as the drug acts as a partial agonist on dopamine receptors and provides an antipsychotic effect. The drug acts as partial agonist on 5-HTA1A, 5-HTA2A as antagonist to provide antidepressant effects for treating MDD. And it also acts as an agonist on receptor alpha-1A, alpha-1B and 2C for regulating the mood and cognition. The drug was approved in 2015, as I mentioned earlier. Now, as this drug is majorly targeting serotonin, so this drug is supposed to give less extrapyramidal symptoms and is found to be a better antipsychotic drug than the rest of the classification. Now, coming on to the indication and dosage, the recommended dosage forms which are available in the market are 0.25 mg to 4 mg in tablet formulations. For schizophrenia patients in adults, the dose is initiated with 1 mg OD and is titrated to a target dose of 2 to 4 mg OD. The maximum recommended dose for schizophrenia patients in adults is 4 mg per day. When the treatment is started, for initial 4 days, the patient is prescribed to take 1 mg OD, and then titration is done to 2 mg OD on day 5 through day 7. Moving on to 4 mg on day 8, based on patient's clinical response and tolerability. For MDD, the dose is initiated with 0.5 mg per day, titrated to a target dose of 3 mg. Now, one point which is to be considered in schizophrenia patients in adults, the maximum tolerated dose was 4 mg per day, but here it is 3 mg per day. And in MDD, this atypical antipsychotic is given in an adjoint therapy, whereas in schizophrenia, a monotherapy is given. So the drug is titrated to 1 mg daily from 0.5 mg, escalating up to the target dose of 2 mg. Dosage increases should occur weekly at weekly intervals based on patient's clinical response and tolerability. The dose is basically based on individual's response to medication. That is how the dose is escalated, and it can be taken with or without food and should be taken at a particular time each day. Now, its use in specific populations. Now, in pregnancy and lactations, as I mentioned earlier, the drug is fairly new and has been launched in 2015 of July. So not much information is available, and more clinical trials need to be done in order to explore about its use in pregnant and lactating women. So adequate and well-controlled studies to assess the risk of Rexulti during pregnancy and lactation have not been conducted. Rexulti should be used during pregnancy only if the benefits justify the risks to the fetus. Moreover, it is not known if Rexulti is excreted in human breast milk. A decision should be made whether to discontinue nursing or to discontinue the drug, taking into account the importance of drug to the mother. Now, its use in pediatric population. Use in schizophrenia. Safety and effectiveness of Rexulti for treatment of schizophrenia has been established in pediatric patients aging from 13 years to 17 or older. Use of Rexulti in this population is supported by evidence from adequate and well-controlled studies in adults with schizophrenia, pharmacokinetic data from adults and pediatric patients, and safety data in pediatric patients from 13 to 17 years of age. For MDD in pediatric population, safety and effectiveness have not been explored yet. Also, antidepressants may increase the risk of suicidal thoughts and behavior in pediatric population. Now, the side effects of the drug. Some of the common side effects are weight gain, dizziness, confusion, fatigue, headache, akathisia, which is generally involuntary movement of the body, tremors, somnolence, which is a strong desire to sleep. And one of the adverse drug reaction, which is rarely seen, is neuroleptic malignant syndrome. So its symptoms can be like hyperparexia, muscle rigidity, altered mental status, autonomic instability. Clinical symptoms may include such as include elevated creatinine, phosphokinase, and acute renal failure. Now coming on to the warning. Increased mortality, as I mentioned earlier, this drug is also used for agitation in people with Alzheimer's. So increased mortality in elderly patients with dementia-related psychosis, suicidal thoughts, and behaviors. So during taking the history of any patient, one should keep in mind that if the drug is being prescribed to an elderly population, the patient is not suffering from dementia, which is related to psychosis, and it may increase the tendency of suicidal thoughts and may increase the chances of death. Elderly patients with dementia-related psychosis treated with antipsychotic drugs are at increased risk of death. Rexulti is not approved for the treatment of patients with dementia-related psychosis. Antidepressants increase the risk of suicidal thoughts and behavior in patients aged 24 years and younger. Thus, monitoring for clinical worsening and emergence of suicidal thoughts and behaviors needs to be done. Safety and effectiveness of Rexulti have not been established in pediatric patients with MDD, as I discussed earlier. Now, why should we use Brexpriprazole if there are these side effects and a warning has been issued against it? So when we classify antipsychotics, there are two classes of drugs, as we all are aware. One is typical, one is atypical. So Brexpriprazole is basically classified into second generation of atypical antipsychotics. It basically works by blocking D2 and 5-HTA receptors, among others. Now, why it is good? Because it targets both positive and negative symptoms of schizophrenia, which is not targeted in typical drugs. They only reduce positive symptoms such as hallucinations, delusions, and disorganized thinking. And also, there is increased risk of weight gain and diabetes, which are minimal side effects for a drug. So yes, these are the references. Thank you very much.
Any questions?
Okay. Thank you. A very good morning to one and all present here. Today I'm sitting here in front of you to present my presentation on the topic Lumborexant. My moderator is Dr. Ayushi ma'am. So here, first of all, you can see in this picture that a girl is sleeping, but she can't sleep. So that's why she is counting the sheep. So moving on to the next slide. This is the overview. So first of all, we should know for what condition Lumborexant is used. Lumborexant is a medication used in the management and treatment of insomnia characterized by difficulties with sleep onset or sleep maintenance. It belongs to the dual orexin antagonist class of medications. This is a new drug. It was approved by the Food and Drug Administration in December of 2019 for use in adults only. This is the chemical structure of Lumborexant, and the chemical formula is C22H20F2N4O2. So when we are talking about Lumborexant, first of all, we should know what insomnia is. Insomnia is a common sleep disorder that can make it hard to fall asleep, hard to stay asleep, or cause you to wake up too early and not be able to get back to sleep. It interferes with daily life and can sap your energy level and mood, but also your health, work performance, and quality of life. So how much sleep is enough for a person varies from person to person, but mostly an adult needs 7 to 8 hours per night. Many factors may contribute to insomnia, including stress, medications,
and an individual's sleep habits and environment. So let's talk about the mechanism of action of lemborexant. So first of all, there are orexin receptors that are located in lateral hypothalamus. So these orexin neurons are situated in lateral hypothalamus and project to wake controlling nuclei in the cerebral cortex, cingulate cortex, nucleus accumbens, dorsal raphe, locus coeruleus, and paraventricular thalamus. So here we can see that there are orexin A and orexin B, which are responsible for the wakefulness of a person. So lemborexant blocks the binding of wake promoting orexin A and B at orexin 1 receptor and orexin 2 receptors and suppresses the maintenance of wakefulness, thereby promoting sleep. This is the pharmacokinetics of lemborexant. First of all, when the drug is taken in the absorption phase, it is rapidly absorbed. Then in the elimination phase, Tmax, that is the time to reach the maximum concentration, maximum plasma concentration in blood, that is 1 to 3 hours. And if a person had an high fat and high calorie meal, the Tmax can be extended to 3 to 5 hours and Cmax can be also reduced. And the half-life is of lemborexant of dosage 5 mg and 10 mg are 17 and 19 hours respectively. The metabolism is done by CYP3A. This is the major elimination pathway. CYP3A inhibitors and inducers can affect the levels of lemborexant too. And this here in the last, we can see the C minimum. It is the lowest concentration of drug in blood. So let's talk about the benefits of lemborexant. Unlike other sleep medications acting on GABA receptors and also melatonin, lemborexant and other orexin antagonists like suvorexant act to counteract inappropriate wakefulness. So it has been proposed that this unique mechanism may come with fewer side effects than more commonly prescribed drugs to treat insomnia, such as benzodiazepines. While still a relatively novel drug, evidence suggests lemborexant may be more effective with less potential for dependence. Furthermore, there is no evidence of withdrawal symptoms or associations with rebound insomnia upon withdrawal of either 5 mg or 10 mg lemborexant in both 30-day and 6-month trials. So this is the dosing information. Lemborexant is marketed under brand name Dayvigo, which comes in 5 mg and 10 mg. The recommended dose is 5 mg, taken no more than once per night and within a few minutes before going to bed, with at least 7 hours remaining before the planned time of awakening. Further, if required, dose can be increased to 10 mg. It is only administered orally, yet the pharmaceutical preparation that is available is in tablets only. Time to sleep onset may be delayed if taken with or soon after a meal. For now, it is marketed in only 6 countries: US, Japan, Australia, Hong Kong, Canada, and also in India. Safety profile. Clinical trial experience shows that lemborexant 5 mg and 10 mg are well tolerated with a low discontinuation rate due to adverse reactions of 1.4% and 2.6% respectively. Somnolence was the most common adverse event reported in more than 5% of patients. Safety in children and pregnancy is not known, and also in geriatric population also. Narcolepsy is an absolute contradiction of lemborexant. These are the adverse effects of lemborexant: somnolence, drowsiness, CNS depressant effects, daytime impairment, sleep paralysis, hypnagogic, hypnopompic hallucinations, cataplexy-like symptoms, complex sleep behaviors, worsening of depression, suicidal ideation. So here I have used the terms hypnagogic hallucinations and hypnopompic hallucinations. So hypnagogic means when a person is having hallucinations when a person is asleep, and hypnopompic hallucinations are the ones when a person is having hallucinations when he or she is awake. These are the references. Thank you. Yes, ma'am. Now let's see the major contradiction. Now, till now, it was approved recently only in 2019. So till now, only that is recommended as an adults only. So pregnant women, children, and pediatric population. In that, we cannot use it. Now, there is no actual evidence regarding this till now. But research is still going on this. Yes, ma'am. Pharmacoscientists. I know, ma'am. Brain function. Different technology.